Morning, Dr. Hopkins.
Good morning, Sir Brian.
Let me explain the arrangements. You're talking to an audience here, which consists largely of participants, infected and affected, and core participants. To your left, there are an assembled group of lawyers who represent different interests in the inquiry. Amongst them is counsel to the inquiry, Ms. Richards, who will be asking you the questions. In the back left, there are representatives of the press. But beyond this room is a larger audience. It'll probably number about 3 figures, both in this building and beyond, watching on either YouTube or live stream. So that's your audience. Mary will invite you to take the oath, and after that, Ms. Richards will begin the questioning. Mary.
Please state your full name.
My name is Susan Hopkins.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Dr. Hopkins, you have a medical degree and an MSc in epidemiology.
Correct.
And since 2006, you've been a consultant in infectious diseases and microbiology.
Correct.
From 2009 to 2018, you worked part-time as a healthcare epidemiologist for the Health Protection Agency and then Public Health England.
I did.
And then in October 2018, you took up a role as Deputy Director at the National Infection Service, and you were responsible for, amongst other things, healthcare-associated infections. Can you just tell us what the National Infection Service was, please?
Yeah, the National Infection Service was a component of Public Health England that predominantly looked after infectious diseases, the epidemiology, microbiology, risk assessments and management of outbreaks and incidents, including providing advice and guidance to the public, ministers and healthcare professionals.
And then you worked for Public Health England in a role focused on the COVID-19 response between January 2020 and September 2021, and you were seconded for part of that time to NHS Test and Trace.
I was.
You're now the Chief Medical Officer and Transition Lead for Clinical and Public Health at the UK Health Security Agency, and you've had that role on an interim basis since October 2021 and then substantively in the post since June of this year.
Correct.
Now, I just want to ask you about the various bodies, the different incarnations, if I may, and I'm going to do that by reference to a statement from Dr. Kiffin on behalf of the UK HSA. Lawrence, could we have WITN 7123001? And we can see it's an institutional response on behalf of the UK Health Security Agency. And if we go to page 3, just want to pick up bottom of the page, the various organisations. So if we go from the bottom upwards, we have the Public Health Laboratory Service, operational from 1940 to March 2003. Then the Health Protection Agency, April 2003 to March 2013. Then Public Health England, April 2013 to September 2021, and then the UK Health Security Agency, established from October 2021, having been established in shadow form. Can I just ask you, I'm not going to ask you about the Public Health Laboratory Service or the Health Protection Agency, but in terms of Public Health England and the UK Health Security Agency, what were the principal differences between those two bodies?
Yeah, so Public Health England, and again, this is an organisation that brought together about 70 different organisations delivering different types of public health in 2013 under the Lansley reforms and the NHS Act of 2012. And it brought together the components of the Health Protection Agency, particularly looking at infectious diseases and external health threats, radiation in particular, but also the public health observatories collecting data in regions and in local areas. it brought together the national components of public health and regional components of public health that had been delivered partly in the NHS and strategic health authorities together into one organisation. So it was there to both protect the nation from infectious diseases and external health threats, but also had a large health improvement component, particularly thinking about obesity, smoking, heart disease, screening, etc.
So that's Public Health England. In terms of the UK Health Security Agency, how does that differ from Public Health England?
So when UK Health Security Agency was commenced on the 1st of October 2021, essentially the role of Public Health England was divided into two. The one part of it became the Office of Health Improvement and Disparities, which very much focused on those health improvement components, obesity, smoking, very much policy areas that deal with large amounts of advice, public campaigns, screening for health in the population, and that went to the Department of Health, alongside the convening body for health inequalities and disparities. UK Health Security Agency actually was formed out of part of the Public Health England dealing with infectious diseases and external health threats, particularly chemical, radiation and environment, but also two bodies that have been set up during the pandemic, one being NHS Test and Trace and the other being the Joint Biosecurity Centre, which brought together 4 nations' data on infectious diseases, particularly COVID-19, to inform ministers and government.
And is there a difference in terms of the geographical remit? Public Health England was Public Health England. The UK Health Security Agency has UK in its title. Is that a distinction?
So I think there's two distinctions. So one is that the UK Health Security Agency is there on behalf of the UK government. And I think you'll have heard a little bit before about how the UK government and then the devolved administrations work. Health is devolved and public health is devolved. So each of the nations have their own health and public health system. UK Health Security really highlights the importance that the UK government, so central government, places on us providing their advice for them on behalf of the UK. We also have specific roles that we deliver on behalf of the UK, on behalf of the 4 nations. Particular to that, I would call out the international health regulations and the international focal point, where we are the organisation that has primary contact with the World Health Organization to notify them of issues that are happening in country, and that the World Health Organization notify us. Equally, if there was an event happening in another country, they would notify us of that event, and we would then cascade the information to the devolved administrations and overseas territories and crown dependencies on behalf of the UK government. So that's an example of what we're doing on behalf of the UK. I would also say that we've been given the convening force, in particularly for looking at infectious diseases incidents. We still do certain things in COVID-19 in relation to all 4 countries, particularly testing, particularly the testing for the National ONS survey, for example, on behalf of the UK. We also have the ability to surge or respond or provide investigation on behalf of the UK and collate data, particularly for COVID-19, but also for other diseases, which we look at on behalf of the UK, working very closely with our counterparts in the health administrations.
And if we look in the same statement that's on screen to page 7, paragraph 2.16 set out what the role and priorities of Public Health England, 4 core functions. Function 1 was protecting the public's health from infectious diseases and other hazards to health. So would it be right to understand that remains a core function of UK HSA?
It does.
Function 2 is improving the public's health and well-being and reducing health inequalities. That is not part of UK HSA's functions. That has gone to OHID.
So the primary responsibility for that has gone to the Office of Health Improvement and Disparities. I would say that we as an organisation have also got a very important role to play in health inequalities, as for many infectious diseases there's a large health inequality aspect, and we are expected and do respond to those.
I may come back to that in that case. Function 3, improving population health through sustainable health and care services. Is that part of UK HSA's role?
No, it's not.
So would that be Department of Health, NHS England and its counterparts in the other nations?
Exactly, Department of Health, and also through the regional teams where the regional directors of public health are now aligned with the Office for Health Improvements and Disparities.
And then building the capability and capacity of the public health system, is that still a function for UKHSA?
It is, and that's a function for all parts of the public health system, but it will, as it relates to us, it is clearly a component that we need to do and deliver. We need to train the workforce for the future, for example. We need to ensure that we have the capabilities and capacity that we need to deliver our core responsibilities. But also we have a leadership role across the system to help enable all of the system to do the best they can.
And then in terms of UKHSA's full range of responsibilities, I think we can see those set out in a letter from Lord Bethell to Dr Harris, the Chief Executive of UKHSA. You've exhibited it to your statement, and it's WITN 7090003, please, Lawrence. So we can see on the first page what this is. And then if we go to page 3, we've got the text of the letter set out, and the first paragraph explains this letter sets out the new agency's role and the government's priorities for the UK Health Security Agency's initial period of operation from May 2021 to March 2022. The second paragraph explains that the UKHSA is the country's permanent standing capacity to prepare for, prevent and respond to threats to health. And then if we go to the bottom of the page, we've got reference there to the UKHSA's role. If we go over to the next page, picking it up in the second paragraph, last sentence, as the nation's expert national health security agency, UKHSA will prevent, anticipate threats to health and help build the nation's readiness, defences and health security, detect, using cutting-edge environmental and biological surveillance to proactively detect and monitor infectious diseases and threats to health, analyse, use world-class science and data analytics to assess and continually monitor threats to health, identifying how best to control and mitigate the risks, respond, take rapid, collaborative and effective actions nationally and locally to mitigate threats to health when they materialise, and lead strong and sustainable global, national, regional and local partnerships designed to save lives, protect the nation from public health threats and reduce inequalities. Now, this was said to be setting out the priorities for the initial period of operation, but does this in broad terms describe the continuing role of UKHSA?
It does, and I think that's also set out in our framework that was published this year.
And if we just go to the next page, just picking up the priorities for 2021 to 2022, we can see reference to continuing the response to the COVID-19 pandemic. I don't propose to ask you further about that, but then 2 says this: build on the legacy of the current response to this pandemic to put in place a resilient and scalable infrastructure that puts the UK in the strongest possible position to protect the public from new and existing threats to health that may emerge, ensuring effective emergency preparedness, resilience and response for health emergencies. I just wondered if you could help unpick that idea of putting in place a resilient and scalable infrastructure. What does that mean?
Okay, so I think what we learnt from the pandemic was that we need to be able to respond in a variety of different ways to new threats as they emerge. We need to be able to scale our detection. So, for example, the building of a testing infrastructure that we did for COVID-19, where we went from being able to test a couple of thousand samples per day to over 1 million samples per day, ensures that there's a resilient infrastructure. We need to recognise that the next pandemic or the next emerging health threat may not be what we've just experienced, so we need to have the operational resilience to be able to flex and be agile in our response to new things that may come towards us, that we may need to respond in different ways. So we are constantly considering what are those health threats, how they might emerge, how they might spread, what are the interventions we might need to do, and where is our resilience in our organisation to deliver on behalf of the country for any of those threats.
Now, the remit of UKHSA in terms of the kind of health hazards that it need to respond to is extensive. So obviously our focus is infectious diseases in this inquiry, but your focus involves nuclear, biological, chemical hazards, for example, as well as infectious diseases. Is that right?
Correct.
But are essentially the same principles applicable to across the nature of the different threats that may be faced, or is there a different approach that needs to be taken?
So I think the principles are similar. So we need to be able to detect them, and we need to have a variety of ways to detect them. We need to be constantly looking at what is the cutting edge technology that will allow us to detect things better. We need to be looking at the ways of prevention and the variety of different ways of prevention depending on the mode of transmission of the infection or how it's acquired by individuals, because each of those will be different. And so we need to have that ability to think scientifically and laterally so that we're able to look at the literature that's emerging, work with the research funders to consider what research needs to be done in the future, and also respond in a capable fashion to a very wide variety of threats.
We can take that down, thank you. Now, we asked you in your statement to consider and tell us how the UK HSA might become aware of and respond to a new emerging threat, for example, of a virus. And I just want to go through certain aspects of the stages. So in terms of detection, you identify in your statement that there might be a range of different ways in which the UK HSA might become aware of that possibility. Could you just talk us through those?
Yeah, so first of all, there's the possibility something emerges outside the country versus something that emerges inside the country. When it emerges outside the country, we have a team that constantly scans the medical literature, the soft areas such as on Twitter, for example, or social media, using the media announcements, government announcements on their pages, and the World Health Organization as critical, that looks at any new and emerging threats that may be happening throughout the world and re-emerging, and on a daily basis assesses those for the likelihood of impact or in our population, and creates a report that is circulated within the organisation and up to the department where necessary. Then there's something that emerges in this country, and in this way there's a variety of different ways that we have of detecting it. Clearly, if we know about it, we have tests that are available to do, and we rely on clinicians delivering those tests to the patients that they're looking after in order to detect those threats that we know about. However, on some occasions, we have clinical syndromes that don't always have diagnostic tests. And in that case, we rely for a certain amount of important clinical syndromes that we've defined on clinicians calling us to notify us of these syndromes occurring. In relevance to this inquiry is, for example, acute hepatitis, but we also have meningitis, for example, or severe pneumonia, and other variety of severe infection syndromes that we may not know what's causing it, but we would want to be aware so we can start investigating. Finally, we have the ability to look at all of the diagnostic tests being conducted in our laboratories across the country, the positive diagnostic tests, and determine whether there's any difference in what's happening this week compared to similar weeks in previous years. And all of those together contribute to how we acquire knowledge on what's happening and determine whether we need to investigate it and work with partners.
And you identify also in your statement that there might be other agencies who might bring concerns to your attention, such as the MHRA or other agencies within the healthcare system.
Correct. So, of course, we work very closely with our partners, not only in England, but also our partners in the devolved administration for any alerts or notifications that may come from them.
And then can we look at WITN 7090004, please? This refers to something called ProMed, the Programme for Monitoring Emerging Diseases. Can you just tell us what that is?
Yeah, so ProMed is something that was launched in 1994, and it's a service that is a voluntary service, and it's free to access. where they essentially collate all information about infectious diseases outbreaks, about new and emerging threats around the world, and send an email alert to people who have subscribed to it on a daily basis and a weekly basis. And you can go online and search for those threats by the area of the world, by the type of threat that you're looking at. And it's a leading source of information for many of us in infectious diseases. The particular example is that for coronavirus, for example, they put up the notification on the 31st of December 2019, and we saw that immediately and started to respond.
Now, the possibility of a new emerging threat having come to UKHSA's attention through one of these mechanisms, or no doubt there are other ways in which it can come to your attention, would it be right to understand that a key next stage will be an analysis or assessment of risk? And you've said in your statement that there are a range of national frameworks and toolkits to assist in relation to that. Just wanted to look at 3 of the documents you exhibit to your statement and see if you can just talk us through their roles. So we have at WITN 7090005 a document. This is a Public Health England document, but it provides operational guidance in relation to a communicable disease outbreak management. Is this still effectively guidance
So it's still extant.
that you use? And what's in broad terms, the purpose of this document?
So this is an operational document. So this is essentially to work with the system, to tell the system how we will all respond and work together in responding to an infectious diseases incident, essentially. So it allows for people in local authority, directors of public health, the NHS trusts, primary care, and national bodies such as the Food Standard Agency that are highlighted here, to have a framework to know what's going to happen when we contact them in relation to an infectious disease outbreak, how we will manage it, what we will do, what our expectations of each other are.
And if we go to page 7, there's a set of standards for managing outbreaks. And we can see there's a number of stages: outbreak recognition, outbreak declaration, outbreak control team, outbreak investigation and control, communications, end of outbreak. Now, again, I'm not necessarily suggesting that you follow this rigidly on every occasion, but in broad terms, does that describe the kind of operational response that you would expect to have if there has been a possible outbreak of a communicable disease?
Correct. I think that the first bit is outbreak recognition is probably the most important. So if people don't recognise the problem, then we don't actually start this process. In terms of the rest, I think it's really important to recognise that not all of it happens in consecutive fashion, that sometimes it can recycle into different stages. I would particularly say that risk assessments occur repeatedly throughout an outbreak investigation. And it really depends on the size. So in some situations, you will have an outbreak of 5 people that is well contained and easy to manage. In other cases, it is much larger, much more dispersed, and it needs a lot more effort and attention, and in some cases can take many years.
Now, this puts particular timeframes for some aspects of the operational management. For example, initial investigation to clarify the nature of the outbreak begun within 24 hours and so on. And then I think we have in the against outbreak control team, OCT held as soon as possible and within 3 working days of decision to convene. Are those the normal kinds of timeframes that you would expect?
Yes, if somebody detects a problem, then we expect an immediate, within 24 hours phone call 7 days a week to discuss that and to perform an initial risk assessment. 3 days is the maximum that we would wait for an initial outbreak control team. And that's the initial outbreak control team is about the system convening. So it may take 24 hours to get all of the right people in a room, virtually these days more than in person. But the idea would be that we have a conversation with a wide range of stakeholders within 3 days.
And then, again, in broad terms, can you tell us how you would anticipate the UKHSA would go about the process of risk assessment? if we take an infectious disease as the example?
So first of all, we do something called a dynamic risk assessment, and that's very much where we get in a rapid situation, we get a group of experts in a room, we are virtually, and we talk through the potential severity of the disease, the number of people affected, whether there's health inequalities involved in those people who've been affected, whether there's political or public information that we need to be able to give to on that scenario, and whether there's rapid interventions that we can need to deliver. All of that together then comes together to grade whether we think it is something that can manage as a sort of what we would say is a business as usual incident where the team who normally manage the disease continue, whether it needs to be managed as a standard incident, i.e. we've got some specialists managing it but it's within the normal remit, or whether it needs to be an enhanced incident with senior executive team oversight and with the strategic director to support the incident director in its management. Then we would go on to do a much more formal risk assessment of the particular pathogen if we knew it was a pathogen, or the toxin if we thought it might be a toxin, in terms of what did we understand about this pathogen, who was it infecting, what were the range of individuals involved, how were those individuals becoming unwell, did we understand what the syndrome was that they were having, how many people were being admitted to hospital, how many people were dying, and we would look at all of the parameters that we could have related to this infectious disease in order to define the full risk assessment. That needs to be repeated, and often in the first risk assessment there are more questions than answers, but it allows us to determine a range of areas of focus, and we mark each of the areas of focus in terms of our confidence in the evidence that's being presented and the impact of that on the population.
Now, a second document which you exhibited to your statement is WITN 7090006. Now, this again is a Public Health England document, but a relatively recent one, December 2020. And would it be right to understand this is still a current piece of work? And we can see this is bloodborne virus-related infection control breaches, a toolkit for risk assessment, investigation, and incident management. Is it right to understand that this is essentially guidance where there has been a possibility of transmission of a bloodborne virus where there's been a breach of infection control? Correct.
So hospitals, for example, but it could also be dental practices, primary care, anywhere else, are asked to investigate any incident that may have had an infection control breach involving a bloodborne virus. And this is a toolkit for them to do it. They can call us with our support, but many parts of the system are very expert in looking back and knowing what they need to do. So this provides a toolkit for them to provide the initial risk assessment and then inform who needs to, whether this needs to be escalated and whether a look-back exercise needs to take place.
So this would not be applicable to, for example, a new bloodborne virus emerging for the first time?
So, I mean, I think that if a new bloodborne virus emerged for the first time, we would use the principles in here, but we may have to develop the diagnostic test. We may not know who and when was exposed in the time frame. So there would be a lot more investigation that would need to take place prior to this. But I think this would form the basis of it, because this is our knowledge that we've gained as an organisation over the last 20 to 30 years of look-back exercises.
And then we have WITN 7090007. This is the UKHSA's incident response plan. And I think it's right to understand this is an all risks and all hazards plan. So it sets out a general approach applicable to all different types of hazard.
Correct.
And again, can you tell us what in broad terms, the purpose of this is?
So again, in broad terms, the purpose for us internally is so that all parts of the organisation know how to respond and know how an incident is going to respond to know their operational things that they will need to support, and that we have a structure that we can hang any incident on and manage an incident in a controlled way with appropriate governance.
And if we just look at page 15, we can see there response initiation, alerting, assessment, activation, and it tells us that this section covers the alerting process for the UK HSA to respond to an incident, notification to staff of the requirement to support that response, and the incident management arrangements following assessment and activation. So is it right to understand this sets out a structured approach to how the UK HSA is expected to respond, and it might be a notification of a nuclear hazard or a biological hazard or an infectious disease?
Correct.
And if we go to page 19, you told us a moment or two ago about the different levels of response, and I think this is what we see set out here. Is that right?
That is correct.
Routine, standard, and enhanced. And then if we go down to the bottom of the page, we've got the heading types of response, as well as the 3 levels of response. UK HSA identifies 3 different overall types of response, and then we have the 3 set out geographically defined, so confined to a specific geographical area, widely dispersed, so where there are, there's no obvious geographical location or pattern, and then over the page, international or global. So does that also affect the nature of the response?
Correct. For a regional response, for example, it would often be led by the regional team with support from national experts where essential, and whereas a widely dispersed would normally be led by the national team, bringing in all of the regional teams and the local teams as necessary. And international or global would need to have close working with the World Health Organization, World Health Organization Europe, and our counterparts across the world.
And then could we just go to one further document, WITN 7090008. This is called the Risks and Issues Register Instructions Guide. Could you just tell us what the purpose of this document is?
So the purpose of this document is a corporate risk register to ensure that as an organisation we acknowledge our risks, we have risks at a operational, tactical and strategic level. And this allows the organisation to understand how to ensure those risks are included, assessed through a standardised framework and escalated through the organisation up as far as the executive team and the Audit and Risk Committee as necessary.
Thank you. We can take that down. Now, you gave us in your statement 3 examples of recent responses to emerging risks. And I just wanted to ask you about each of those in turn, relatively briefly. The first was the identification in the States of infections in infants who'd used a particular prescribed dried baby food. Mm-hmm. Could you just talk us through the nature of the risk and the action that UK HSA took?
Correct. We got a notification from US colleagues via the CDC that they had detected an unusual gram-negative infection in babies, and that they mixed the risk factor that brought these collection of unusual infections together was a particular dried baby food product. MHRA and the Food Safety Authority were notified, and they released a notification to withdraw the product from market. However, when we reviewed the data, we recognised that, first of all, it could be prescribed as well as bought over the counter. And secondly, we needed to make an assessment about whether there were any such cases in our country for the time period. So we reviewed all of our microbiological data available, and as I explained before, we get all of the positive data from the NHS labs across the country. We did not detect any of these infections in the age group that would have been prescribed it, but we worked with MHRA and the Food Safety Agency and determined that we should still inform prescribers as well as just withdrawing it from the shelf in case they still had some as stock, or that they had given some prescription to an individual before it had been withdrawn. so that they could inform the individuals to not feed their baby that product. So we released an alert to inform them of this and asked them to withdraw the product.
And what was the kind of time frame of that process that you've described?
So our initial assessment process for detecting to see if there was any of these infections took about 7 days. Once we had determined that there were no infections but that this product could still be on the shelves, using data from the NHS Business Services Authority on their prescription data, we released the document in about 7 days' time.
The second example...
Well, may I just ask, the notification to people who might have the product on the shelf went from you?
No. So those that had the product on the shelf would have gone from Food Safety Agency or the Medicine and Health Regulatory Authority. And I think in this case it was a food, so it would have come from the Food Safety Agency as a public health withdrawal notification.
So your notification went just to the prescriber?
Ours went to the prescribers and hospitals, so to ensure that hospital pharmacies were aware, community pharmacies were aware, and that prescribers were aware.
Did that involve a time lag at all between the MHRA telling those who had it on the shelf, or the Food Safety Agency telling people if they had it on the shelf? And the prescriber being told? So
it did, because we were only informed of it once it had been withdrawn from notification, and we needed to do an assessment to decide whether it was a prescribed product or not. And so we needed to do that assessment with the NHS authority that holds the prescribing data, and assess whether this was in a prescribed drug.
And although on this occasion, thankfully, no infection resulted, that period of time, how long a gap was there? If, for instance, the Food Safety Agency or MHRA notified everyone, including hospitals and pharmacists, straight away, that might have been quicker.
It would have been quicker.
How much quicker?
I would have to double check my records, but at least a week quicker.
Yes. Is there a lesson there for the future?
Yes, I think that, and we discussed it at the time as part of our lessons learned of the review, was that we should inform both prescribers and pharmacies, as well as withdrawing it from shelves at the same time.
Thank you.
In relation to that last answer, Dr. Hopkins, is there a review on every occasion where there has been something reported and a response taken, or was there... is that only undertaken in certain types of response? So
anytime we have an incident, we afterwards we perform an after-action review, looking at all of the lessons identified and how we can incorporate those into our best practice moving forward, including with other organisations that we work with.
And what would define an incident for those purposes? So
this was defined as an incident because we were investigating a potential outbreak.
The second example you gave was relating to investigation of clusters of hospital cases of a rare hospital-acquired pathogen. Can you just talk us through that?
So again, we see across the country hospital-acquired pathogens, and that was the area that I particularly looked at previously, particularly bacterial infections that arise in hospital. And often when these bacterial infections arise in hospital, there's no obvious source or common source attached to it. But we ask the NHS hospitals to send the national service, so in UK Health Security Agency, our national lab, if they've got unusual strains of bacteria, or if they see a cluster of a couple of strains together, so that we can type and see if they're the same or whether they're different. In this occasion, we saw these strains come from a number of different hospitals in a short period of time, and we performed a rapid investigation to determine were these individuals being exposed to something that was in common use across these hospitals. What we found was that they were using something in common use across the hospitals, a type of cleaning product, and we reviewed that cleaning product and determined that it was potentially contaminated and should be withdrawn.
And if we look at WITN 7090010, is it right to understand that this is the National Patient Safety Alert that was sent as a response of that investigation?
That is correct.
And if we go... Oh, no, I think, in fact, if we go over the page... This is the baby Formula One, I'm sorry. I think it may be that the wrong document's been exhibited, because your statement describes this as the patient safety alert in relation to that association with the ultrasound gel.
Apologies, we can correct that for you and send you the right one. But it would be a similar type of thing, going to a similar audience, where we are able to rapidly notify organisations to inform them of an action that needs to happen.
And again, just in relation to this particular instance, this particular pathogen, what in broad terms was the time frame from the first investigation to the sending out of the patient safety alert?
So I would need to double check, but I would have thought that from the very first sample coming in to sending out the alert was probably 4 to 6 weeks. 4 to 6, not 46.
And then the third example you've given related to a recent hepatitis outbreak in children, which was fairly widely reported in the media. Can you talk us through that, how it came to UKHSA's attention, and then what steps were taken?
Yes, so actually this is a good example of where the devolved administrations and UKHSA work very closely. So they've, on a Friday afternoon, Scotland notified us that they had cases of severe hepatitis in young children requiring a transplant. And they were going onto the transplant list. This was unusual, and therefore they were investigating the source of this unusual infection. They were going to do two things, and with our support one is to notify World Health Organization of this unusual event, and two, to ascertain were there other cases that had not been notified. Immediately that weekend, we discussed with our NHS blood transfusion colleagues to see if there had been any other young children requiring an organ transplant or being put on the organ list, and also asked all of our specialist hepatology colleagues around the country to inform us if they had unusual numbers or unusual cases of acute hepatitis in children. And very rapidly, we acquired information that there was an emerging cluster of cases happening in young children with no predetermined or normal causes of hepatitis being found. That it required a very large investigation, working with many partners to determine what this might be. As we found over the range of months and weeks we investigated, it was likely to be a combination of unusual viruses affecting these children at the same time, and potentially some part of their own immune response, and they're causing this vigorous reaction. I think it was a good example of how we work together across the country, but also how we work with partners, NHSBT in this place, in understanding the organs transplants was this an unusual finding. It was also important that we work very closely with academic partners to try and investigate what the source or the type of pathogen that might have been there, as we did not know. And then ensuring that we communicated with the public and with families as much as possible to inform them about what we knew was going on in this emerging incident.
And in terms of providing information to clinicians so that they could potentially spot whether they had cases that needed to be investigated as part of this process, whose role was it to provide that informational guidance directly to clinicians on the ground?
So first of all, in part of our role is to inform people by briefing notes and inform people by guidance documents, and that's and then we work with NHS England to ensure that's disseminated to the right people. And so in situations like this, we use a combination of the information flows that we have, particularly our close links with infectious diseases and microbiology colleagues in all of the NHS trusts, but also working with NHS England to make sure the cascades of information through trusts and down to teams takes place in a timely fashion.
And with whom in Scotland, Wales and Northern Ireland do you work for the equivalent purpose?
So at our incident management team meetings, we would have a lead representative from the public health agencies from each of those countries, who would then work with their relevant health service and public health colleagues to inform and cascade the information.
Now, can I ask you a little about, first of all, how you engage with external experts. So the UKHSA will have its own internal expertise, but because of the breadth of the kinds of matters which the UKHSA may have to investigate and analyse, would it be right to understand that there will be frequently a need to obtain expertise from outside?
That is correct. Yeah, and so we have a variety of different ways of doing that. So firstly, I would say we have the expert advisory groups or committees that are led by the department, and that are Department of Health and Social Care. And we particularly work with the Advisory Committee for Dangerous Pathogens, the New and Emerging Respiratory Virus, Viral Threats Advisory Group, and other similar groups because they have national experts that have already committed and signed up to being on these expert committees and to public principles. So those would be our first starting point. The second is that as part of our work with the National Institute for Health Research, we have a number of commissioned health protection research units that have been commissioned through their research excellence by the National Institute of Health Research to work with us. And those are on the vast majority of the areas of work that we deal with, and have experts in academia that we have very close links with and are usually our first port of call if we need extra work. And then finally, we have a range of experts that are recognised nationally and internationally as experts that we would pick up the phone to and contact, email, and ask for their help and assistance as required. People also come and volunteer their help with us and would email particularly me or colleagues to offer their help for new and emerging infections. I think one of the things that we have done throughout COVID or since COVID, and with a number of the incidents that we've seen, hepatitis as an example, and also monkeypox, is develop rapid technical groups, which allows us to bring together UKHSA experts along with academia, industry or other partners to allow a wide range of people to show emerging evidence into our risk assessments, which we then publish as transparently as possible in a timely manner. I think that's been new and novel, and a very much improved way to ensure that we're sharing the evidence that we're learning ourselves, but also the evidence that academic partners are willing to share with us in a timely manner, often before it's published, many months in some cases, and use that to inform our risk assessments and our technical judgments.
And then to what extent does the UKHSA work directly with, engage directly with patients and patient representative organisations?
So by and large, we're one step removed from patients. We do have some directly patient-facing services in some areas, but often we are working through the intermediaries of the clinicians working in hospitals. And so usually that's where our first port of call would be, to the professional groups of the clinicians working in hospitals and their relationships. However, we do have established relationships with many of the patient organisations in relation to various different infectious diseases, or in various different groups, and those are places that we'll make a first point of call. I think monkeypox was a really good example of this, where within 24 hours of detecting a case in a gay and bisexual or men who have sex with men, we reached out to Terence Higgins Trust, the AIDS Trust, and other partners, so that we could involve them in our decision making as patient advocates.
And then in terms of providing information to patients or the public, what's the UKHSA's role and approach to sharing information publicly? So
I believe that we are a transparent organisation, and we publish very readily on the information that we have. I think the technical reports that I mentioned are really a nice example about how we publish early, often with incomplete findings, but show that those findings are still emerging, and show our confidence in those findings, to allow us to be able to be as publicly transparent as possible in what we are finding. We also communicate directly with the public through our media teams and our communications teams. We release press statements and press reports and social media reports and commentaries on a very wide range of topics that we are dealing with.
And if we just pick up something in your statement, so if we go to WITN 7090001 and go to page 10, please. Paragraph 7.4, you say here, the IMT, so that's the incident management team, would make a judgment as to whether there's a need to inform patients directly or to use publicity and communications as a method of case finding. In these instances, we may involve a relevant patient group if such exists, but as an IMT is configured to take rapid action in an evolving situation, this may not be easy. Many situations arise outside of the NHS or in community settings where patients are not under direct clinical care/supervision. Often clinical specialists are used as a proxy to represent their patient group. Now, just trying to unpick that a little, is it right to understand from the first sentence that the expectation would be that there would be some form of publicity, and what's being described here is a choice as to whether the information is communicated directly to patients or through clinical intermediaries, or whether it's a wider social media public communication?
Yeah, so I think there's two separate things here. So first of all, if a clinician has performed a diagnostic test, it is their responsibility to inform the patient of that diagnostic result. As a clinician myself who still practices, that's part of my role. What we're talking about here is where we're trying to find more individuals where we don't know where they have infection yet, or where we want to inform them of a potential risk that may be there. So, for example, in the case of food-borne outbreaks, where we need to warn people about uptake of food or withdrawal of a food, the Kinder Eggs near Easter was an example of something that we dealt with recently. So that is a method of going publicly to inform people. We saw throughout COVID, for example, the public information about what were the symptoms and what actions to take. That was supplemented by contact tracing, so contacting people who were contacts of a case and giving them specific information and specific additional advice. But the results of their test went either directly to them or to the clinician involved in their care, rather than through the incident management team, who would not be involved in that sort of management of the individual case.
And if we could look at WITN 7090013. We've got a set of guidance here. Again, it's got the Public Health England stamp, but I assume it's still current guidance. Management of a public health incident where public or patient recall or notification may be required. Guidance on risk assessment, look-backs and public or patient notification exercises. So I want to ask you about a couple of sections of this, but in broad terms, what's the purpose of this document?
So again, this is setting out what is the response of the system, not just the response of UK Health Security Agency, but NHS bodies and others, where we need to recall individuals to potentially look at their care pathway or inform the public about a particular risk.
And if we go to page 6, we'll see in paragraph 1.2 the distinction you've drawn in your oral evidence, distinction between contact tracing and public patient notification. And then if we go, please, to page 9, the section headed Policy and Legal Context, just want to pick up what's said at the bottom about the duty of candour. So paragraph 2.5, the duty of candour regulation enforced by the CQC is to ensure providers are open and honest with the people who use the services and other relevant persons acting lawfully on their behalf, in relation to care and treatment. It also sets out some specific requirements that providers must follow when things go wrong with care and treatment, including informing people about the incident, providing reasonable support, providing truthful information and an apology. Now, what's the relevance of the duty of candour for the work that UKHSA does?
So I think the work that UKHSA does can be divided into two different parts. So the work that we do as a national organisation providing advice and guidance, where we would often give information to the NHS Trust or to an NHS organisation providing a clinical service on why there is a duty of candour issue, what are the information they should be including in their duty of candour, and what components around that. So I think that's the first bit. Secondly, as an organisation which delivers laboratory services, some of those being within the NHS estate within certain trusts, or with laboratory services at a national level. If we had a problem with the way a test was conducted, the result of a test, then we as an organisation would have a duty of candour to inform that patient of the problem that we had with the test and the problem with their test results. So two aspects. One is supporting other statutory organisations on their function or individuals, and the second is our own organisational duty of candour. And of course, us as clinicians also have a duty of candour if we had detected something and were involved in the direct care of that patient.
And in relation to the first of those, do you at UKHSA detect reticence on the part of clinical providers to comply with the duty of candour? Have you had to persuade organisations to be open with their patients?
I couldn't give you an example that I was involved in that has occurred. I think that we support NHS organisations in ensuring that they provide the full information. So in recent examples that I've been involved in, for example, were related to infected heart valves a number of years ago that caused rare infections. And in that sort of situation, we would provide the organisation with a lot of information that we think that they should provide, and show them, tell them exactly how they should do it, and looking at their records. And they can take a little while to get up and going, but once they do, then they usually deliver the letter, the information, and the training often to their staff to ensure that they inform their patients in a readily manner. I would say that, you know, as a clinician who's been practicing, I think the duty of candour has come on and changed quite a lot over the last years, and I think people are now have much more of an expectation of delivering it than perhaps existed 10 or 15 years ago prior to the Francis Inquiry.
And then if we could go in this document to page 16. But sorry, I should just perhaps pick it up at page 14 so that we can understand what page 16 is then applying to. So we've got stages of public health investigation, and the first paragraph, there are 5 steps in the management of an incident where a population may have been exposed to a public health risk. This could be an agent, infectious, chemical or radiation, or failed healthcare process, or equipment that results in a potential harm. And then the stages are set out. I don't propose to talk through each of those, save to note if we go to the next page, paragraph 4.4 refers to the public patient notification exercise and says once the risk assessment's been completed, a public patient notification exercise may be indicated. If we go over the page, we can then pick up at the bottom of the page under the heading proportionality, a discussion about whether there should be a public patient notification exercise, a PNE. So it says in each incident, the risk assessment must be used to determine whether the benefits from carrying out a PNE justify the potential harm from undertaking such an exercise. As noted above, some of the factors that might lead to a PNE being carried out may need to take account of other factors and not solely the public health risk assessment. And then the next page identifies a list of factors. I won't read through them all, but we can see the first bullet point refers to the seriousness of the harm, and the second to the probability of the exposure to the risk leading to a poor outcome. There are then references to risks of anxiety, either in the notified or wider population, a risk that PNE could cause harm, and then a number of bullet points which essentially set out what might be described as the disadvantages of carrying out a PNA, so resource implications. And then the last bullet point, reputational harm caused to the organisational programme through loss of public confidence. In broad terms, does this still represent the approach that's taken to assessing whether a PNE should be undertaken?
So I think there's the factors that should be considered. I think the default would be that a PNE should be carried out and that people would need to play the alternative sources on what the harm might be. I think this also comes from the idea that it is not a decision that's made by a single organisation. It should be made by the organisations in delivering that care to the individual patient or to the group of patients who are involved. And so it needs a consensus-based approach. It needs to consider all of these things. It needs to document all of it as well in an ideal way so that we understand the decision-making framework and what things were considered. However, I think on balance, it is usually a preference to notify unless that there is evidence of very little harm that is going to be caused and of high anxiety, or the other component is that there's no good screening test or diagnostic test that we can use, and that can make it particularly challenging to notify, because then you create a lot of anxiety but without giving them a diagnostic test or a treatment option or a support option. However, again, I would just say that for infectious diseases in particular, I think that informing people of their diagnosis and giving them information about how they can support themselves being well, even if there's no recognised treatment, and also helping them prevent transmitting to others is a very important part of patient notification exercises for those particular infections, and would always be considered as a priority.
And the potential relevance of these factors, in principle at least, is self-evident in relation to some of them. Just looking at that last bullet point again, why would the reputational harm caused to an organisation or programme ever be a relevant factor?
I mean, I think, if I'm speaking personally, I think it shouldn't be a relevant factor. That should not be a factor that should be considered. I think that the organisation may want to consider what the reputational harm might be and how they would mitigate it and how they would communicate. But it shouldn't be a factor in not doing the notification, but should be a factor in considering how they're going to put things in place to do things better the next time.
And one factor that it might be said isn't identified here is the idea of the person's right to know, essentially an autonomy right. Is that something that you would consider should be part of the decision-making process?
I think you're right, it should be, and it should be probably included here as for clarity.
Can I then ask you just a little, we can take that down, thank you, about something called the precautionary principle. So a principle that the inquiry has explored in a number of hearings with a number of different witnesses. What's the role of the precautionary principle in the work undertaken by UKHSA?
So the precautionary principle is a sort of philosophical way of describing thinking about things twice and going slowly to make sure they do no harm. And so really that's potentially when you're introducing a new test or doing something in a different way, or you've got a variety of different components, that you ensure that what you're delivering is not going to cause harm or an unintended consequence. I think that in the delivery of much of the work that we do, we constantly think about the consequences of what we're delivering, and we look and learn from things that have happened in the past. I think that the challenge of the precautionary principle can be that people can do things to such an extreme that it can cause other complications or consequence, or it could cause treatments not to be delivered that might be life-saving on one hand because of a potential challenge down the line. And I think that's why we have the regulators, and I think in many of the interventions that we deliver in therapeutics and others, that's why we have a sort of framework through the regulator organisations to decide on what's reasonable and what's not. I think in terms of the precautionary principle for other aspects of public health, in thinking of population and what we're doing, then again I think we need to consider, is there any consequence in what we're doing that might cause harm and that we could prevent by taking another course of action or by going slowly. It's often looked at in terms of how we can improve air quality, because removing things from there is not thought to be a bad thing. But there have been other aspects in infectious diseases where the precautionary principle has been considered. A particular example relating to hepatitis was trying to cure one infection in Egypt meant that hepatitis C is likely to have been transmitted very widely. So it really is thinking around the edges, making sure that you've thought about consequence, making sure that you consider a range of factors that might be related and whether you should do something at this time or not.
You told us about the work that's done within UKHSA on a constant and ongoing basis, scanning the worldwide medical literature and other sources, social media, publications put out by or announcements by other governments and health bodies and so on. Is there a point in that process where UKHSA effectively performs an educative role in relation to clinicians? In other words, you might not yourself be investigating a particular risk and taking specific steps in relation to that risk, but you think there is material that's emerging from elsewhere in the world, for example, that it would be useful for clinicians to know about. Is there some way in which that is disseminated, or a system for that?
So we have a number of ways to disseminate information. So the first is we use something called briefing notes, and our briefing notes are disseminated to our regional teams, from national teams or from a notification to local authority directors of public health, and within the NHS particularly to infectious diseases and microbiology doctors in primary and secondary care. And they're particularly there as the sort of reservoir or the people within a local hospital who would then go on to communicate more widely and teach and do the majority of teaching and education roles within trusts. If there was a particular area, we would also speak to specialist societies, particularly if we thought there was a new and emerging infection relating to neurological conditions. We would speak to those experts and ask them to disseminate through their professional organisations. And for example, with monkeypox, again, a recent example, we worked very closely with the British HIV Association and the British Association for Sexual Health and HIV, again, working with partners so that they are then helping to disseminate it to their members. We'd give webinars to those sort of groups where we would just basically advertise it widely and disseminate. But I think one of the important components in a lot of the work that we do is that when we speak publicly to the public, we are also educating health professionals, and we are doing that because it is the most direct way to talk to people. And so actually often when you speak to very small groups, you'll never get to the right group, and which is why we try and make statements about the outbreaks we're investigating, the incidents that we're looking at in a very public way.
And then you touched on health inequalities when I was asking you in general terms at the outset of your evidence about the difference between Public Health England and the responsibilities of UKHSA. Just to return to that, how does then health inequalities issues factor into UKHSA's work?
Yeah, so every time we look at data, we try and analyse what are the inequalities that are sitting within this data. So we look at protected characteristics, age, gender, sexual orientation, ethnicity, religion, etc. But we also look at a range of other factors that may play a role. So we particularly in infectious diseases look at individuals who inject drugs, individuals with certain health conditions that may be more likely to develop consequence. We look at individuals from certain populations, groups and parts of the world where they arrive to the UK because they're more likely to have certain infectious diseases. So we want to ensure that people are aware that health services are thinking about their delivery to these populations, and that we work very closely with these groups and populations at a local and regional level in order that services that are provided by the NHS are there to deliver what they need.
Yesterday when Dr. Rain gave evidence on behalf of the MHRA, I asked her about the MHRA's response to the Cumberledge review, the first Do No Harm report. Has the UKHSA had any involvement in responding to that report that you know of?
Not that I'm aware of, because it was particular drug and procedure based.
Last question from me for now, Dr. Hopkins, is you've described a system that in many respects is a very different system from the systems that the inquiry has been examining in the 1970s, 80s and 90s. What would you say are the main strengths of the current system? And what would you say are any weaknesses or areas for improvement in the current system?
So the strengths of the system, so first of all, I'll say the people working in the system. We have a very dedicated workforce who will always go out to do whatever they need to. Secondly, that we have a very wide variety of practitioners. I think that really helps. So we have epidemiologists, public health physicians, infectious diseases, clinical microbiologists, psychologists, etc. So a very wide team that we can call upon and draw on their strengths. We have very close relationships with academia, so that allows us to work with them to develop new cutting-edge methodologies. And I hope also that we're a learning organisation, and we constantly learn from what's happened before. And I think many of us have been involved in the care of patients over many years. And I like to think that we therefore think about what they would want and hold that at the centre of everything we do. So that's the good things. So I think the bad things is that there's been a lot of organisational restructure, and every time there's an organisational restructure, there's a loss of organisational memory and institutional memory. For me, actually preparing for this inquiry allowed me to learn a lot of the history of the various types of organisation rather than just considering the component that I work in. Secondly, the structure outside of us as an organisation has changed widely and is under pressure for a lot of reasons that are not infectious diseases or external health threats, so they maybe feel less important. And I think particularly in the 70s and 80s, prior to HIV, hepatitis and other threats emerging, that people thought infectious diseases was sorted and that they didn't need to take effort, they didn't need to prepare for it. We had enough work. And I think we've all learned to our consequence that that's not the case, and that new threats continually emerge and we have to be at the ready. And we've seen that in the last couple of years as well. I think there's also a fragmentation in the public health system, that we spend a lot of time and a lot of effort trying to cohere and cohese. But there's over 150 local authority directors of public health with their small teams. We've got regional health protection teams, we've got teams in the NHS, we've got teams in national government. And so therefore, we as a new organisation are working very hard to try and set out principles about how we work together. But that involves time and energy that could be doing something else. So I think changes in the system and changes in how people work and deliver definitely provide challenges. And one of the things that I'd like to hopefully see is some stability for the next 20.
Thank you. So those are the questions I was proposing to ask Dr. Hopkins, timed perfectly, of course, for the morning break. And if we can use that break to invite call participants to suggest any further lines of question to me.
Yes, well, we'll take a break until 11:45 and come back then and see what further questions there may be.
Thank you, sir.